Good afternoon. Thanks to each and every one of you for joining us today for the new web series Fertility Updates organized by Fertility Forum of India. I, Ankit Dogra, along with my teammates Dr. Deepika Chabra and Ms. Ramit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, welcome all to the first episode with experts in the field of improving IVF success. The academic partner for today's program is the Naari division of Jagsonpal Pharmaceuticals Ltd, makers of PRORETRO, 10 mg tablets of micronized dydrogesterone, assisting motherhood, delivering happiness, along with EndoReg, 2 mg tablets of dienogest for medical management of endometriosis and endometriosis-associated pelvic pain, and Fibristone, 25 mg tablets of mifepristone, a safer alternative to surgical management of uterine fibroids. Dear attendees, post your questions, suggestions, or clarifications in the Q&A box to be answered by the experts. Please note this webinar is streaming live on the Facebook and link is shared in the chat box. Also note for future reference, this webinar will be uploaded on our YouTube channel, Jagsonpal Medical Insights. Now let us welcome the facilitator of the program, Dr. Jyoti Malik, Director of Roots IVF and Fertility Institute at JJIMS Bahadurgarh, to kindly initiate the web series. Over to you, ma'am.
Thank you so much. Thank you, Mr. Ankit. Thank you, Jagsonpal, Dr. Deepika, and everybody for giving us this platform. Welcome all the participants. And this is the first web series where we would be talking on how to improve the IVF success. So here we have our speaker, Dr. Rama Raju sir, who would be taking up the topic of analyzing an IVF failure. And then we would be having our esteemed embryologist, Dr. Priya Kannan, who would be then discussing about how to choose the right embryo. And then we have a QA session where we ask and they answer. So we have the expert commentator, Dr. Manish Banker, sir, for it. So Dr. Manish Banker is Medical Director, Nova IVF Fertility Centers of Ahmedabad. Nova is the largest IVF groups in India, and Dr. Banker has been awarded BC Roy Award by Medical Council in 2017. He has been the past president of ISAR and has been a member of board of many organizations. Welcome, Dr. Bankers. And for this talk, I would invite our speaker, Dr. Rama Raju sir. Dr. Rama Raju is the founder and director of Krishna IVF Clinics, Visakhapatnam, and he has his area of knowledge, we can see, is LH polymorphism, DNA fragmentation, vitrification, poor responders, diabetes, male infertility. So we have a very out of the box topics that we would be coming up with, sir, in our further series as well, about assisted hatching, PGT research, everything. So over to Dr. Rama Raju sir. So please, so that we can start the talk, and then the comments and some maybe the talk would be at the end of the session. Dr. Banker would give the comments. Over to you, sir.
Thank you, Dr. Jyoti Malik. Thank you for giving me the opportunity to share some of my views on the area of analyzing an IVF failure. When we look at analyzing an IVF failure, it's like a game of puzzle. You have to look into multiple factors. I would say that we are looking at close to 35 to 40 factors when we analyze an IVF failure. We can divide them into 4 major areas. One is the patient and the environment of the couple. The second is the stimulation protocol. The third is the embryology information. The fourth is the transfer. The fifth is the post-transfer monitoring of the cycle. And then looking at the immunological factor. In this way, we can analyze an IVF failure. In this lecture, I'll be basically concentrating on the clinical aspect of the analyzing of the IVF failure and to a very little extent on the stimulation protocol. And in the question and answer session, if Priya Kannan has not covered some of those topics, I will answer the embryological perspectives, how I see as a clinician. I send warm greetings from Krishna IVF Clinic and my team. And when we look at an IVF failure, we can divide them into couple characteristics: the stimulation protocol, the embryo, the transfer, and the implantation. So in a failure analysis, it boils down to three things: the process of the manufacturing of the embryo, the transfer of the embryo, and the process of the implantation of the embryo. In this talk, I'll be concentrating more on the couple characteristics, the stimulation protocol, and to a little extent on the embryo. And the transfer and the implantation, we'll leave it at a later point. When we look at marital life, the importance of marital life is the concept of time to conception. When we analyze some of the information, and then along with Manish Banker, we produced a newsletter in 2019 by a title called Time to Conception. There were a couple of publications on the time to conception and the outcome of pregnancy. If the time to conception is very long, then there is a higher instance of pregnancy loss, a higher instance of ectopic pregnancy, a higher instance of premature delivery, and a higher instance of perinatal morbidity and mortality. So when we look at marital life, we also should give importance to the concept of time to conception and its implications. The same applies to the IVF pregnancy. The second area in the couple's characteristics are the maternal age. Why I said maternal age is the number of euploid embryos we are going to get is based on the maternal age. And there is a U curve of the maternal age. If the woman is very, very young, that is between 18 to 22, there is a higher instance of aneuploidy. And then there is a drastic decline in the aneuploidy and significant amount of euploidy embryos come in. And then at the age of 35, you again find a significant rise of number of aneuploidy embryos, and that rise reaches a maximum at 41 years. Till now, we are looking at maternal age only as an oocyte factor, but we are not looking at maternal age in relation to the number of embryos that are available, euploid embryos. So that is one area, and there is an abrupt change in the percentage of euploid embryos from the time they cross 35 years. That's an important thing. And similarly, the paternal age is coming into play in the role of aneuploidy embryos, and more so when they're crossing 40 years, provided there is a significant difference in age between the women. A woman of lesser age of less than 35 with a male more than 40 has more euploid embryos compared to both the partners being 37 years or male partner 40 years and the female partner more than 35 years. The next area is the body mass index. We seldom look at male's body mass index in relation to sperm morphology and fertilization rate and the outcomes. We, a couple of years back, published a paper showing that high BMI is associated with increased time to conception, lesser amount of good number of embryos, and higher incidence of abortion. And in Indian context, we also found a 50% incidence of comorbidity of diabetes. In high BMI, with and without diabetes, there is an effect in the number of euploid embryos. Similarly, as in the female, there is a higher lesser implantation at the higher BMI. When we look at couple characteristics, we should analyze that in the failure, are these the contributing factors, and are these, how many cumulative factors are there in this situation? The next is the medication. We seldom ask what medication the woman is taking, what medication the male is taking, and then are the couple healthy, and what are the health issues. A lot of times male does not tell us anything about the number of antihypertensive drugs they use, whether they are in the right diabetic control. The second thing is the role of immunological problems. Similarly, the same applies in the area of immunological problems. The role of antihypertensive, especially the calcium channel blockers, and the role of SLE medication in the female, which has drastically increased in the recent years. When I say SLE, I also speak about the collagen disorders and the rheumatoid. And we do not ask this, and we do not understand the implications of these drugs on the stimulation protocol, on the implantation rate. So we should create a checklist of all these factors to look into how much these make an impact in relation to the outcome. Then when we come into the ovary, the number of oocytes make a huge difference. And did we assess adequately before we start a cycle that we adequately assess the antral follicle count, and whether we did a recent surgery or there were multiple surgeries, which in turn may predispose them to a lesser number of oocytes. And did we do a proper assessment of the ovary? Because lots of times we take the ovary for granted and then start the dosage at a particular dosage, not validating the information, which in turn will let us into a situation of tinkering with the dosage too many times during stimulation protocol. The data suggests that as ovarian assessment, the antral follicle count, the AMH, the possibility of lower ovarian volume, and the previous surgical history will help us to tailor the stimulation protocol in a much better way and increase the number of oocytes that are available for this procedure. The other area which we give importance is the fibroids, but to a lesser extent, we don't look at early adenomyosis. The reason is, in early adenomyosis, there's a change in the size of the junctional zone, and evidence is coming in that if the junctional zone is higher, there's a lesser amount of implantation. So in the assessment, are we looking at the size of the uterus? And the size of the uterus makes a huge difference in understanding the volume of the pathology. The second thing is in understanding the placement of the embryo transfer catheter during the embryo transfer. The role of anomalies, as we understand, a unicoordinate uterus will have a much lesser chance of implantation compared to a normal uterus. And the concept of junctional zone should be emphasized. The fibroids is much discussed topic. Adenomyosis is coming into forefront in recent years, but the concept of junctional zone as a parameter to look into in an IVF cycle is never emphasized, which I'll be discussing in the coming slide. The other information is we keep on concentrating on the tuberculosis, but we seldom look at it in a deeper plane. Is this the tuberculosis a past infection or a present infection? The second thing is the hydrosalpinx. We sometimes overemphasize the hydrosalpinx and do not give a judgment of what size the hydrosalpinx will make a difference of surgery, and the impact of salpingectomy on the ovarian volume, on the ovarian reserves. It should be a trade-off between these two things which make a difference. And of late, what we are finding is we're doing an infection screen. The instance of papillomavirus, the instance of mycoplasma and uroplasma much more than the chlamydia. We are running a PCR-based panel, and we were surprised to find that 5% of our IVF population are having HPV, uroplasma, and mycoplasma. And a surprising thing was very few amount of chlamydia was being picked up. And as you know, a papillomavirus decreases the implantation and increases the pregnancy loss. And if both the partners are human papillomavirus positive, their carry-home baby rate significantly drops down. This is one of the findings which we are looking at for the past 2 to 3 years. And that's one learning we learned in these 2 years. When we look at health, the age, which I have discussed, sperm quality, we always think one sperm is adequate for ICSI, but one sperm is not adequate to give a pregnancy. There's a huge difference. Improving the health of the male makes a huge difference, which in turn improves the health of the sperm and also gives a better pregnancy. If there is an uncontrolled diabetes, there is a lesser amount of fertilization, higher amount of biochemical pregnancies, and this we published in the Journal of Andrology in 2013 or 14, titled Non-Insulin Dependent Diabetes, an effect of sperm chromatin abnormalities and reproductive outcome. So if you are finding your patient who is a male with uncontrolled diabetes, let him have the diabetic control cycle. Similarly, if the patient is on calcium channel blockers, we prefer to stop the calcium channel blockers and then only do the cycle. The last area which we seldom discuss is the role of occupation of the male, especially with the rising pharmacology industry in India. We see a huge number of them being chemists and are exposed to the multiple environmental toxins which affect the sperm chromatin studies. So we feel, apart from a good analysis and a morphology, chromatin studies and DNA fragmentation should be done, and improvement of the health emphasis should be done before a cycle is taken, which will in turn reduce the chance of failure in the given cycle. Similarly, as I have discussed, autoimmune disorders, if the male or the female is in the active stage of the disease, we are finding that the fertilization rate, the quality of embryos are decreasing. So whenever we find an autoimmune disorder, be it in the male or the female, it can be as simple as very aggressive psoriasis or as severe as rheumatoid or multiple joint severe rheumatoid arthritis, or even the immunological and the collagen disorder, the Crohn's or the ulcerative colitis. We try to avoid doing a cycle during the phase of these active health problems, because there we are finding a decrease in the fertilization rate and also the decrease in the quality of the good quality embryos, and not last but the least, a poor implantation and higher pregnancy loss. This is an unpublished data which we will be publishing in the coming years. And as I emphasized, the role of diabetic control in the male and in the female is very important before we go ahead for the cycle. In the stimulation protocol, once we have analyzed and did a checklist of that we have taken adequate precautions for these variables, or when we analyze a failure, we discuss with the patients that these can contribute to increasing the number of cycles, and then looking at the stimulation protocol. In the stimulation protocol, one is, did we give a good starting dosage, which is based on the AMH or AFC, the age, and the BMI, and did we give adequate stimulation? And the role of LH in a good stimulation protocol comes only in an ongoing hyperresponder or in patients with LH polymorphism. And the monitoring we do depends on the individual policies of the clinic. But we at Krishna IVF do a little more closer monitoring of the cycle. I would say, when I say monitoring, we do more of surveillance rather than monitoring, and see that what the number of oocytes we are planning to get, if we reach that number. And if we reach the number, we feel that we did a good stimulation protocol. Then once we go into the IVF cycle, so these are the factors I would like to discuss with the patient when I fail for an IVF cycle. Then I would like to add the role of junctional zone, which I was discussing a minute ago. This we published in the Ultrasound in Obstetrics and Gynecology as a paper, and then also published in IEEE journal as an AA article, where we showed that the junctional zone in the pregnant group and in the non-pregnant group are different. The upper black line, which you see here, here you see a junctional zone, which is monitored right from the beginning of the cycle. This is the non-implantation group, where you find a higher junctional zone. And look at it, it's not 10 millimeters, it is coming closer to 4 millimeters. And in the pregnancy group, the orange group, where you find the junctional zone is lesser, and it is seen right throughout the cycle. And this we could also use by artificial intelligence and made it an automated plotting and published it. And Samsung has patented it. In the coming years, they might come with this software application as a tool for monitoring the junctional zone during stimulation protocol. With the advent of time-lapse, we are finding fascinating data of embryo assessment. When we analyze a cycle, if the embryo has a good PN appearance time, a PN disappearance time, the first cell division, the second cell, 2 cell, 4 cell, 6 cell, 8 cell, and the morula, you're finding here is the data of where we transferred 2 embryos and 2 live births. You see the whole, these are the number of the patients and the well numbers here. They fall into a particular line of minimum and maximum. That means analyzing the embryos will also give you the cause for the IVF failure. So these 24 embryos or 12 patients which had 2 embryos transferred each, and then they are plotted here, they're falling exactly in the same plane. When we come into another set of patients where we transferred 2 embryos and did not get implantation of even a single thing, you find an erratic behavior of the time lapse. So the quality of the embryo is also an important thing, and we get predictors with the use of technology of time lapse in assessing the failure analysis. We use this chart to tell the patient that, look, your embryos are crossing have a delayed time appearance of 2PN, or a delayed appearance of 2 cell division, or sometimes we say your embryo had a reverse cleavage or a direct cleavage, and which in turn affects the implantation potential. So we feel these are the information which will help in analyzing an IVF failure. when we analyze an IVF failure, we never speak about the information, we never become judgmental. We tell these are the possible reasons that have caused this failure. And based on this information, we tell them what are the chances for the subsequent cycle and what are the factors which we can modify and which we can't modify in relation to a specific amount of time, because time is also an important pregnancy. If we postpone the next cycle by a couple of years, the whole scenario changes. So using the combination of factors which I discussed till now, some of them can be modified, some of them can't be modified, and give them a realistic prognosis. One thing we should always remember is IVF was never designed to be a single cycle, and your failure analysis is you're speaking about what are the possible implications, various factors act, and what precautions you can take to improve in the coming cycle is all about analysis of the IVF failure. With this, I leave the topic for discussion.
Thank you very much, Dr. Rama Raju. You have rightly taken us through the journey of, from a clinician's perspective, how do you analyze the possible reasons for a failure? And a few points which I think we should stress upon more and are generally not done so are the general health patterns or what is called lifestyle of the couple. Because on the one side, we want the couples to enter into an IVF program at the earliest. And on the other side, to make significant improvements on lifestyle takes time. So this is always an area where we will have to strike balance. And the classic example is a couple who has a high BMI. Would you postpone the cycle, ask them to lower their weight and come back after 3 months, or would you start their treatment? This is a constant dilemma. The other very relevant thing which you mentioned was the medications that the couple are on, or other autoimmune disorders or other comorbidities, which also need proper attention and address to be addressed before we put the patient on the IVF cycle. The third, again, difficult challenge is how do you assess sperm quality? People have methods of looking at oocyte quality based on how the oocyte looks, but how do you really assess the quality of the sperm other than looking at the count, the motility, and the type of motility? What is the impact of the DNA fragmentation or sperm chromatin, or do we have any other method? This is more so important that when you're doing an ICSI and you're manually selecting a sperm, can you improve by any method whatsoever to select a better sperm from the entire cohort that we have? And one other huge variable which a lot of people are talking about is the embryo transfer technique, because some clinics have what is called an embryo transfer provider, because they've seen that the success rate of different clinicians using embryos coming out of the same lab is different. So how can we standardize the process of embryo transfer, which in one aspect is the most crucial and the critical step, and on the other aspect, every consultant does it possibly differently. It is the least standardized of all the procedures, because every consultant feels that he does the best embryo transfer, whereas honestly speaking, there is no standardization of this very, very critical step. So there are a lot of things which need to be analyzed, and it would be good to listen to Dr. Priya from the lab, because I believe 65 to 70% of the success lies in how do we create the embryo. And once we have her talk, then maybe we can have a more deeper discussion on this very challenging topic.
Right. Thank you so much, Dr. Banker, sir. I think we leave the house open, and after Dr. Kannan's discussion and the talk, then we can have more insights into what all you have focused upon, and we can have all the answers from both of you, Dr. Raju, you, and all the embryologists as well. So now I invite Dr. Our expert commentator for this, Dr. Sarabpreet Singh, and he is IFS ASHRAE certified senior clinical embryologist at Artemis Health Institute since 2009. He is director of Fertilis Academy, which provides online hands-on teaching in reproductive medicine to the postgraduates across the globe, and he has been awarded the ESAR Award champion at the conference in 2020. He has been awarded many awards in applied genetics, PGT, and I'm sure today your presence would make a lot of difference to how best we can select a good embryo. So welcome, Dr. Sarabpreet Singh. And for the talk, we have Dr. Priya Kannan, the Director, Embryology, Garbha Raksh, I think you'll have to speak it out, Dr. Priya. And Dr. Priya is past president, ACE India, has authored many chapters, and over to you for your talk. And then we come on to the whole discussion of the whole thing.
Thank you, Dr. Jyoti, for inviting me. It indeed is a very nice topic, and it's a pleasure to be here and to see Dr. Raju sir, and it's been a long time. It's to share the stage with him is my honor. Whenever we are talking about selecting the right embryo, what we are actually looking at is which embryo to select and which embryo not to select. So I'll be just going through a few of the salient features of how we do it. And I'll be concentrating more on morphology because that still is the most common way in which we select the embryos, and then touch upon other technologies as well. The methods that we use are, number one, the static morphology, which is the most commonest and the most used and still being used one. The next one is the continuous morphokinetic assessment, which is our time-lapse, metabolomics, and of course we do have the PGT, which is the pre-implantation genetic testing, the aneuploidies, in which we can do either by analysis of the blastomia, which is in the cleavage stage, or analysis of the trophectoderm, which is the trophectoderm biopsies, and also in the used media. So we do have all these avenues to select embryos right now, and we'll be going through one of each of that in a step. Let's talk about the morphology, which is the time-tested, the longest ever method that is being used right now, which is based on the selection of embryos based on the morphology, that is how they look, which is again subdivided into the rate of the embryo development. A positive selection criteria in morphology includes the number of blastomeres, the absence of multinucleation in the blastomeres, early cleavage to the two cells by 25 hours post-insemination, and the low percentage of cell fragments in the embryos. And of course, on day 5, when you see it is a blastocyst morphology. We just have to say in one line, it just have to say you look fine and you look good. And then that's how we select the embryo. But the more important thing to look for in morphology, and which is what we do look for in morphology, is the rate of development of the embryos. But any embryo selection that we have should be simple and reproducible to all clinics in the world, and more so easily trainable, because that's what exactly we train our next incoming embryologist. The selection method for morphology is different at different stages. It is a sequential selection. It is not as static as we mention it to be. It is sequential. It is done at various stages. Number 1, at the pronuclei stage. Number 2, at the cleavage stage. And number 3, in the blastocyst stage. Of course, we do on all these days, the 2PN stage, day 1, day 2, day 3, day 4, and day 5. The most common days in which we check are day 1, which is the FER check, which is a mandatory thing that we must all do. The next step is usually on day 3, where we see the number of good quality egg cells that we have, and then straight on to day 5, unless otherwise somebody wants to transfer on day 2 or day 4, when we go ahead and check. Otherwise, the day 1, day 3, and day 5 are the usual selection days on which we look at it. Though there are lots of methods in which we do. There was a Istanbul Consensus Workshop which happened in 2011, which gave us the sort of a uniform way and a simplified way in which we can do the selection of the embryo grading and the assessment. The most important thing to have in mind when you're looking to select embryos is to look for the embryos and assess the embryos based on which we select the embryos at a particular time. And this time is always based on hours post-insemination. The first check should be done for 17 hours plus or minus 1 hour post-insemination. A syngamy check can be done 23 hours plus or minus 1 hour. Early cleavage check for IVF is 28 hours plus or minus 1, and ICSI is 26 plus or minus 1 hour. So approximately, if we don't want to do combine these two, and approximately you can do it at about 25 hours. The day 2 check, which is the embryo should be assessed at 44 hours post-insemination, day 3, 68 hours post-insemination, and day 4, 92 hours post-insemination, and day 5, 116 hours post-insemination. We have to stick to these timelines for uniform. Whenever I say a FIR check, when I say a FIR check or anyone says a FIR check, we should be talking in the same language. And hence, to stick to this timeline is extremely important. First of all, just to keep you in the same tune as we all do, the embryo assessment does not start only with the 2PN. It actually starts with the assessment of the oocytes as well. That just a lot of oocytes, I have a lot of pictures, but then we'll skip and we'll go to the important one of what parameters actually affect implantation. The sperm, the smooth endoplasmic reticulum, if it is severe, it is detrimental, and polar body, if it is large, very large, it can be detrimental. Large vacuoles and large dark clusters are the only one that has been shown to have shown to be detrimental with the publications that has been here so far. Sorry about that. And the next stage in which we check is the day 1. That is to see if the oocyte is fertilized and to assess certain parameters in the oocyte, the fertilized oocyte or the zygote, to see if we can assess certain based on certain criteria. The number of criteria that has been mentioned in Scott by the Scott et al. Or has been numerous. That is the number of nuclei, PN centering, pre and proximity, PN orientation, NPB number, NPB polarization, NPB symmetry, and the cytoplasmic halo. However, what we do check right now are much lesser. One that we must all check is for the presence of multiple pronuclei. But apart from that, what has been shown to be of importance, apart from, or this is based on the 2001, sorry about that, 2011 Istanbul Consensus. What has been, even in that, the cytoplasmic halo has not shown to be beneficial. I'm sorry, I have missed to change that. But what has been shown to be of detriment is if the PN is not centered, or the PN proximity is not there, or the PN orientation is controversial when the NPB number is much lesser, that is less than 6. The bullseye, as we call it, is not good. The NPB polarization has been shown to be beneficial if strong, and NPB number, if the NPB number is more than 3 but no polarization, has to shown to be detrimental. But however, cytoplasmic halo, whether the presence or absence, has not shown to have any effect on the implantation rate. What to do when we have 1 PN? The Asper consensus was that if the zygote has 1 polar body and 2 pronuclei, it should be discarded. Whereas if there were 2 polar bodies and 1 pronuclei, it is the individual laboratory decision whether to select or deselect that particular zygote. The Istanbul Consensus made it very simple to say if the pronuclei were symmetrical, it is equivalent to Z1 and Z2 of the Scott grading. If it is not symmetrical, but other arrangements, including peripherally sited pronuclei, it is abnormal if the pronuclei is 0 or 1, with just a 0 or 1 NPB. Next, we move on to the cleavage stage embryos, which of course we know still remains to be the most widely used stage for embryo transfer, while slowly in certain cases where some of the labs are moved to completely blastocyst transfer, and some use blastocyst transfer as an on-need basis. Excuse me. This also has to be done on strict timeline basis. The selection criteria for cleavage stage embryo is based on the rate of cleavage of the cells, the number of cells present on the day of transfer, the size and shape of cells, multinucleation and fragmentation. The time points is 25 hours post-insemination. Everything is post-insemination. Kindly remember that. The day 2 would be on 44 plus or minus 1. The day 3 is 68 hours. And day 5 is 116 hours plus or minus 2 hours post-insemination. In terms of early cleavage, the decision to perform a second day 1 assessment is at the discretion of the laboratory. Many laboratories may or may not do it. Maybe either the syngamy or an early development, but not both, just to avoid the exposure of the embryos outside of the incubator. However, if anybody has a time lapse, then they can go ahead and assess all these things from their desk. They don't have to take the embryos out of the incubator. The purpose of the second assessment after the fertilization check can be for either quality control, which is the syngamy, or prognostic early cleavage, which will define the assessment of the time selected. It has been shown by various studies previously that the presence of an early cleavage of the embryo is any embryo which has got an early cleavage has got a higher implantation rate. Those are the pictures of a early cleavage with the 2 cell with just one single nucleus in both the cells. Here in the next one, you have a lot of fragmentation and also multinucleated blastomeres. Of course, these are all the other development. After the early cleavage, all these criteria comes into play to assess the embryos, which is the development rate, everything I have mentioned already. On day 2, we want to have at least 4 cells, and the fragmentation rate should be less than 20% and no multinucleation. Those are the pictures of the day 2 embryos. On day 3, it is about 68 hours plus or minus 1 hour. We should have at least 8 cells, and the fragmentation again should be less than 20% with no multinucleation. As such, this is the 8 cells with and without fragmentation. On the left side is the row without fragmentation. On the right is the row with fragmentation. As you can see, there is compaction in the 3rd row in the lower row, and a presence of a compacted embryo on day 3 could be a good sign for that particular embryo in terms of a higher implantation rate. Just to say a few terminologies when we are talking about selection and deselection of an embryo. An arrested embryo is one that has not cleaved in the 24-hour period. A slow embryo is one which has got 6 or fewer cells on day 3, but have cleaved during the preceding 24-hour. A normal embryo reaches 7 to 9 cells by day 3 with less than 15% fragmentation and no multinucleation, and has cleaved in the preceding 24 hours. An accelerated embryo is one which has got more than 9 cells on day 3. And what is a fragment? We've been talking about fragment quite often when we are talking about cleavage stage embryo. A fragment is a anuclear membrane-bound extracellular cytoplasmic structure. The parameters that affect implantation in cleavage stage are the blastomere number. If it is less, is detrimental. If it is up to date, that is 4 to 5 on day 2 and 7 to 9 on day 3, it is beneficial. An uneven embryo, multinucleated embryo, blastomere, and severe fragmentation are detrimental to the implantation rates. And that is the description of the staging of grading of the embryos as mentioned in the Istanbul Consensus. And they have made it quite simple for us to use it. Now, just to take a few points, and I will also like to mention a word about the blastomere size. Whenever we are looking at 2-cell stage or 8-cell stage, there are 3 different sizes in which we can see. Whenever the embryos are the 2, 4, or 8 cell, that is the even cell stage, all the blastomeres must have the same size. Whereas in an even odd cell stage, that is in 3, 5, or 7, there can be 1 large and 2 small blastomeres, such as in a 3-cell stage, there can be 1 large and 2. Even then, it is called an even embryo. However, in a 8-cell stage, if you have 2 large cells and the rest are small, that is, they are still called uneven blastomeres. To say how to select the embryo, are we justified in selecting the embryo based on how they look on or the rate of development? There has been lots of publication, but I would just like to mention a few here. The embryonic morphology score to predict the implantation and live birth rate. In a study of about 158 cycles, 28% was a live birth rate, and with the birth rate, live birth rate of 37.3% morphologic state was highly predictive of both the implantation rate and the live birth rate. The implantation rates by the group, they're 54% in group 1. That is, the group 1 is a test of the embryos. Group 2 had 30% of implantation and live births. That is the group 2. That is the average. The worst was in the group 3 and 4, which had much lower implantation rates. And hence, as we should always keep in mind that the embryo grade, that is the morphology, is highly predictive of implantation and live birth rate and can be used to determine the number of embryos for transfer. In a day 4 embryo, as we can see, that is the grading, but then of course, not many labs use the grade 4 for either transfer. And hence this is the day when we usually skip the grading and go straight to, we don't expose the embryos to outside of incubator at all. We go straight to day 5. And those are all pictures of some of the embryos. Here you can see a small blastocele even forming on day 4, which is a very good assessment, which is a very good feature in terms of implantation potential. On day 5, the assessment should happen 116 hours post insemination, and we assess the blastocyst based on 3 parameters. One is the blastocele size, the inner cell mass, and the trophectoderm. And those are 2 good examples of blastocyst. And there is the Gardner score, which has always been there from 2000, which is based again on grade the size of the blastocele, the ICM, the tightly packed or the loose packed ICM, and how the trophectoderm looks like. And then we also have the grading based on that, from the best, which is the 4AA, to the poor one, which can be 4CC. However, based on the Istanbul Consensus, it has also simplified based on the same. And it is easier to keep a picture like this in the lab to correlate between ICM, trophectoderm, and the blastocele size for easy visualization and assessment of the embryos. However, what we must always remember is that the morphological criteria which we use in the cleavage stage is insufficient to predict the developmental potential later on. And notably, in many cases, if we are not able to assess the euploidy, the euploid status of the embryo. Just to know whether the morphologic grading of the embryo of a euploid blastocyst influences implantation and ongoing rate. There was a study which had this study, and where they have come to the conclusion that excellent quality embryos, here blastocysts, yielded statistically higher significant implantation rate compared to good, average, or poor quality blastocysts. Whereas the average quality blastocysts yielded a higher implantation rate compared to poor and poor quality blastocysts. These were euploid embryos, and hence even if the embryo is euploid, you can still, the better quality, the morphological quality had a better implantation rate than the poor morphological quality implantation rate. And the higher the better the quality of the morphology, the lesser was the spontaneous abortion rates as well. And what is the association between the grading and implantation rate? Again, in another study with the euploid blastocysts, the blastocyst morphological grading was associated with the implantation rate for euploid embryo transfers after adjustment with the confounders. These findings suggest that evaluating blastocyst morphology could be critical to selecting the best euploid blastocyst. So somebody who is not doing a PGS, that is the PGTA for the blastocyst, could still have a better implantation when selecting the better quality embryo based on morphology. And when we are looking at blastocyst, now that a lot of clinics have moved from cleavage to blastocyst, whenever we know, and there is one thing, there was a study which said that the more the number of usable blastocysts in your culture system, the better is your culture system. One of the first criteria in which we assess what the basis of our culture system, the assessment or the functioning of the culture system, is the percentage of the good quality usable blastocysts we derive on day 5, sorry. Because when we have the result, it's already 2 weeks later than the embryo transfer. So a sudden drop in the good quality usable blastocysts is one of the first indicators to show the when there is any issue with the culture system. So when we are assessing the embryo blastocyst, to have whether the live birth rate with the cleavage stage embryo, correlation between the cleavage stage embryo quality and the embryo development speed. And then this was a retrospective study with 3,386 single vitrified warmed blastocyst transfers. They are classified the blastocysts based on the morphology to 1, which is the best, 2, which is BB, group 3 was the BC, and group 4 was the CB. And they studied the effect of the cleavage stage embryo quality and development speed when correlating to the clinical pregnancy and live birth rate. The higher implantation rate was observed in group 1 compared to group 2, 3, and 4. And the same trend was also seen when the better clinical pregnancy, better live birth rate was seen in group 1. And it also showed that the groups with the embryos of AA, AB, and BA had higher than the BB group rates. In the BB groups were higher than that in the BC and CB groups. The miscarriage rate increased from the lowest it was in the group 1 and highest it was in group 4. So the selection of when you are basing your embryos selection based on morphology, the better quality embryo or the best quality embryos will give you a better implantation, live birth, clinical pregnancy and live birth rate, and a lower spontaneous pregnancy rate. The proportion of day 3 blastomia, this was a key finding in this study. The proportion of the day 3 blastomia cell when more than 8 on day 3 had a better implantation, blastocyst development, implantation, live birth rate than when compared to embryos which had less than or equal to 6 embryos on day 3. And was there to study the effect of morphology and age on a sustained implantation rate in euploid blastocyst transfer? It was concluded that for all ages, the sustained implantation rate for day 5 good quality blastocysts were higher than day 5 fair, poor, or day 6 blastocysts in the study. When there was a our own Dr. Gauram Majumdar had published a study between to show the relationship between morphology, euploidy, and implantation potential of the cleavage and blastocyst stage embryos. He had concluded that blastocyst morphology and the rate of development were found to be significantly associated with euploidy, whereas the cleavage stage morphology was not. And that is the huge drawback of cleavage stage assessment. The implantation rates of good quality euploid cleavage stage embryos were higher than that of poor quality embryos. The implantation rates were similar for all transferred euploid blastocysts, irrespective of the blastocyst or the morphology. Hence, the take-home messages for the morphological assessment of the embryos of selecting or deselecting an embryo is the morphological criteria is the most commonly used, but is insufficient to predict their developmental potential and the euploid status of the embryo. The pregnancy rates are higher with top and good quality embryos, and spontaneous abortion rates are higher with poor quality embryos. The embryonic factors have less role in top quality embryos. In poor to average quality blastocysts, blastomere number on day 3 can help selecting the embryo. Clinical pregnancy rate was higher for blastocysts of low quality compared to low quality cleavage stage embryos. Coming to the next way of assessing the embryo, time-lapse imaging. When you want to select an embryo, the next option that you have is time-lapse imaging. While it has been able to help in selection of the embryos, till now we are not able to find a clear clinical benefit for the use of time-lapse imaging. That is, we are unable to show a success, an increased IVF success rate using this. However, when there were studies which claimed that when there was a small meta-analysis, it showed that it probably is not because of the time lapse, because we still don't have an established algorithm to select the embryos based on time lapse. It could be because of the uninterrupted culture of the embryos. There are lots of AI, artificial intelligence, being used in time-lapse imaging, and a lot of algorithms are being tested right now. And some we are yet to see what could be the benefit of that. We still need a lot of data to come to help us select the embryos using time-lapse imaging. But however, where it definitely helps in selecting the embryo is to deselect the embryo. Embryos which were shown to have, these were terms that we got to know only after time-lapse imaging came around, which is a direct cleavage of embryos from 1 cell to 3 cell and a short time as a 2 cell. And the uneven blastomeres at 2 cell stage and multinucleation at 4 cell stage or after that also, which it's difficult to see with the microscope, or reverse cleavage. These are all the criteria using which we can deselect embryos when you have a time lapse. The other way to select an embryo is was a metabolomic assessment. Sorry about the spelling mistake. Well, there has been some very weak evidence that shows that metabolomic technologies might be able to predict the viability of the individual embryos and implantation rate. But however, we don't have much of that being used right now. Then with a lot of better uniformity of protocols, it might come into use, but as of now, it is not one of the chosen methods for selection of embryos. Of course, the next one and the most important one that we are looking at is the PGT. PGTA, as we call it now, and PGS, as it's fondly still called us. We are looking at for the euploidy of the embryo, which is what is the hot topic for the day, whether to use PGTA on all patients or to select the patients. As of now, there are only very few indications for pre-implantation genetic testing using aneuploidy screening, which is women of advanced maternal age, couples with a history of recurrent pregnancy loss, couples with repeated IVF failure, but can it be used in male partner with severe male factor infertility is another indication. The most recent studies have shown that embryo selection through aneuploidy screening can increase the chance of implantation and definitely decrease the miscarriage rate in the indicated subgroup of patients who are going for ART. However, it is not shown to improve pregnancy rates when it is used on all embryos that are available. The clinical benefit of this strategy in good prognosis patient and egg donation programs should be assessed by properly designed randomized trial, especially if single SET is requested. Because we are yet to establish an increased pregnancy rate in this particular group of patients when PGTA is used. The maternal and neonatal outcomes are reassuring. However, when you are selecting the mosaic embryos for embryo transfer, appropriate genetic counseling should be given to the couple prior to doing the transfer. While we are looking at the invasive, that is the trophectoderm biopsy for PGT. There is the other imaging emerging method, which is the non-invasive PGT. There are two alternatives to the invasive biopsy, which is a blastocentesis, which is the analysis of the blastocyst fluid from the blastocele. The other one is the examination of the spent culture media. This has already started coming into the market. However, what it detects is the DNA in the media, and it could have origin from outside as well. It could be paternal, maternal, or the extra DNA, my DNA as well when I'm in the lab. And hence we have to be extremely careful when looking at this. However, there are labs starting to offer this. The max that we have, the matching of the sensitivity of this has been around 80%. We would like to have it much more. Some labs claim it to be about 90 to 95%, but I think the jury is still out, not yet decided on whether we can still, the technology is as good as the invasive analysis. Thank you very much for that opportunity, and I would be very happy to take any questions.
Thank you so much. That was excellent, actually, Dr. Priya. Both the talks by Dr. Rama Raju and you have been excellent. So over to Dr. Sarabpreet Singh for the further comments and for further discussion regarding the talk that Dr. Priya has just finished.
Yeah, hello, Dr. Priya. How are you?
I am fine, Sarabpreet. How are you? Long time again.
Yeah, long time. So it was a nice lecture. Embryo selection is actually the most important factor which predicts IVF success all over the world, actually. And despite standardization, subjectivity in morphology cannot be bypassed. It's very difficult to train the technicians and embryologists at the same level. And having said that, despite the availability of PGT-A and morphokinetics, time-lapse studies and all, morphology still remains the mainstay of selection, all over the world. It's very difficult for people like, in a third world countries like India to afford technology like time-lapse. We are not living in the US and Dubai. And it's true that deselection is actually better than selecting embryos. At times when you have a cohort of embryos, deselection is actually an easier job compared to, selecting the best out of the three. It's easy to deselect one. And if you do a sequential embryo assessment, you can look for negative attributes like cell asymmetry, multinucleation, and, stage specificity. At some stage, it was asymmetric or non-stage specific. So you can rule that out. But you need to train your eyes and because eyes see what mind knows. So you need to train your brain, and then your eyes will automatically start seeing the what others don't see. I would like to ask you, Dr. Priya, I mean, what importance do you give to things like 2PN scoring if you're getting good blast? Another question I would like to ask Dr. Raju, because at some point of time I was talking to Dr. Madan, and they were doing a lot of day 4 freezing and vitrification, and even day 4 ETs for that matter, if I'm not mistaken. But freezing is, Dr. Raju, I think you were doing day 4 freezing quite a lot. Because I have been talking to Dr. Madan off and on, so.
No, actually we do the fresh embryo transfers on day 4 and allow the other embryos to progress to blastocysts and then vitrify the extra embryos.
Okay, on day 4 itself.
No, like the fresh transfers are on day 4.
Okay.
And the extra embryos are allowed to go to blastocysts, and then they're frozen on day 5 evening.
So, sir, why not day 5 transfers? I mean, you get much more information on day 5 compared to day 4.
Actually, after learning from time lapse, I don't think day 3, day 5 will really make a difference when you look at the morphokinetics and the velocity of the embryo from the time lapse. But before that, it was a call that Madan took. But now I realize in hindsight, the day 4 embryo may not look beautiful. But you have a compaction, then you know that that's a faster cleaving, faster dividing embryo.
And do you think that choice of media also influences compaction, the time of compaction?
Now, since we are using a single media, it really doesn't make a difference. We have moved to, from the time lapse, we are using a single culture media. Earlier, we used to use it the 2-step media. Now we are using a single media.
And you don't
uninterrupted cultures.
And you don't change the media, you keep it the same from day 0 to day 5? Or?
Yeah, because in time lapse, what happens is if you change the media, the optics change. And then there's an interruption of the media, so there's a breakage. So the media we use is the single media, right from the time it's fertilized, post ICSI or post IVF. Most of the time, all of them are post ICSI. Okay. It's a single media, and nothing is changed in between.
And if I may ask, which single media are you using? I mean,
we're using the jerry-based media right from the beginning, from the time we brought the time lapse. And the other thing is, it's sort of a group. It can be considered as a group culture. The reason is the interval are connected by small connections, and the distance between each well is around 45 micrometers, which corresponds to the concept of Gardner of distance between 2 embryos, and the beneficial effect of group culture is when the embryos are close together.
True. And Dr. Priya, do you believe in autocorrection? Suppose that you see multinucleation. This is also correct. So findings like there are articles which say that 3PN also corrects. At times, so multinucleation and other negative findings, do you believe they're correct? Because later stages are given more importance compared to earlier stages. So that might be one of the reasons, because the viability and autocorrection has taken place at that stage of embryonic development.
True that. Thank you, Sarabpreet. First of all, hello, sir. Raj, sir, how are you, sir? It's been a pleasure seeing you today. To answer both of your questions, Sarabpreet, number one, how much do I assess the 2PN when I'm doing a blast culture? 2PN, I mean, it is not, the 2PN assessment is never done under the microscope, just for the sake of the audience. We take a picture and then do it. Because when you keep going up and down on the microscope, it takes a very long time. And hence it is recommended not for all the, or if, for example, if you have like 10 embryos, just to go through it, it takes a long time. So we take a picture and then assess it later. But however, I don't think I assess that much when it comes to 2PN. Probably I am particular about making a note of whether there is the orientation, whether they are centering is there, they are adjunct or they are adjacent or away from each other, the pronuclei. And of course, the presence of 3PN definitely is a deselecting factor for me. Whether it corrects later or not, I think all the 3PN embryos will definitely become a beautiful blastocyst. That's something I've seen forever, but I generally don't tend to transfer them at all. That is a deselecting factor for me. Whether it corrects or not, we don't know. So I don't know whether we can go ahead and transfer them. It still is
that was just an example. What I meant was,
I'm just saying in that. Yeah, in multinucleation also, there has been various papers in terms of multinucleation, which said that not all multinucleated embryos need to be abnormal. But however, multinucleation is one of the factor, if present, can have other abnormalities. It is present, multinucleation is present in 88% of the times when there is another abnormality which will happen in the embryos later on, such as a direct cleavage or reverse cleavage or something like that. Multinucleation is present in 88% of those embryos in the later when they have a abnormal morphokinetic development. And hence probably, this is probably one of the indicators which we can straight away see when we are using a morphological criteria. But if you have a time lapse, you can still go ahead and see what is happening to that. And better, if you are doing PGTA, you can definitely assess what's happening to it. But if it's a euploid embryos, you can choose to go ahead and transfer. But not all centers, and it's not applicable for all patients as well.
True. True.
So Dr. Priya, do you base your decision of choosing the embryo based on morphology, or you always use a time lapse?
I don't have a time lapse. So mine is only either morphological assessment or on the PGTA.
Okay.
But then it's, I don't have a time lapse because it is not just the cost. I think as of now, we don't have a scientific basis to say that it has improved the success rate, apart from having maybe it can improve. If you still close your incubator completely and keep it, it could have the same effect. But as Raju sir has said, it's got that wells which can give the act like a group culture. It has helped in that way. But then as of the studies, it is still not improved the success rate to justify that huge cost investment.
So it gives a solace to so many of us who have joined that we don't have a time lapse, but still we can do, I mean, morphometrics is something that we have to depend our judgment
Yes.
on. And if Dr. Priya, such a big embryologist, can do that, I think we all should feel happy that, okay, those who don't have a time lapse should not feel depressed and all that they are not doing good work. And Dr.
I'm just hoping that, sorry to interrupt, I'm just hoping that I can visit Raju sir's lab to learn a little bit more about his algorithm at some point of time. Once COVID is down, I'm visiting you again.
Yeah,
Yes.
Sonia ma'am wanted to say something, ma'am, and then Dr. Rama Raju sir wants to comment.
I was just going to congratulate both of them. Excellent lectures, which was expected, and that is why I made it a point to join today, because I knew that this seminar is going to be really, really good. Congratulations to Dr. Raju and Priya, of course. She's a sweetheart, our favorite. Two questions, one for Dr. Rama Raju and one for Priya. I am quite intrigued to know that you are majorly doing day 4 transfers, because that is something which is not talked about much. Even in literature, it is either day 3 or day 5. And you have based your insight has been based upon the time lapse majorly. You feel that it is the time lapse which is causing it. And in your clinical lecture, you said that you're giving a lot of importance to the diseases that the patient has, and also to the medication and BMI, etc. So now, have you done a subgroup analysis to see whether this is affecting the growth in male infertility? Because after day 3, it is the male partner which is responsible for the growth of the embryo. So if you have a lot of patients with male infertility and you're doing a day 4 transfer, what is it that you find over there which is helping you? Number one. The second thing is, are you doing a day 4 transfer also for the poor responders? Because they say in that the earlier you do the transfer, the better it is. So these are the two questions for you. After you've answered, I will ask Priya.
We have been doing day 4 transfer since 2008.
Okay. Yeah.
That is not now.
Yeah. Okay.
And the concept was genomic activation happens after the 2.5 days.
Exactly.
Or 3 days.
Day 3.
So that was one of the reasons. The second thing is, we are not bothered about the good looking or the bad looking embryos, because day 4 looks ugly.
It does, yes.
Compared to a day 3 or a day 5.
Absolutely.
But what happened is, we found with time in the initial years, majority of the work was male factor infertility. Now the majority of the work is hyper responders.
Hyper? Oh, you're lucky. We have
hyper responders.
We have poor response all the time.
I mean, poor or hyper responders.
Achha, okay, yeah.
I mean, in the initial years, majority of the work was male factor infertility. Okay. Now, in the last 5 years, majority of the work is suboptimal responders or
Yeah.
hyporesponders.
Hypo, yes, yes.
Failed IVF cycles is the majority of the work.
Yes, yes.
But when we decided for day 4 embryo transfer, we were looking at compaction and non-compacted embryos, which was an indirectly way of looking at the speed of the embryo development, because you never know the speed of embryo development. Conventionally, after the embryo reaches 8 cell, you don't know which time. But when we're doing the embryo transfer on the 90 hours to 95 hours, and your embryos are compacting, they're far better embryos compared to a non-compacting embryos. That was the principle in which my colleague Madan, who happens to be a pathologist, and both of us got trained in Belgium and with Tiniberg. In Belgium, we were fortunate to have the training for both for the PGD, that is the fish-based, and the PCR single-based, cell-based. So those backgrounds have helped us, because we used to do the extra embryos genetic evaluation. So from that time, we decided to go for the day 4. But from 2010, earlier we used to do the embryo freezing at day 3 or day 4. We decided we allow the other embryos to reach blastocyst and divide them into 2 groups, the one which reaches blastocyst on day 5 and one that reaches blastocyst on day 6, and and make them the sequence of numbering, so that we are going to transfer the day 5 blastocyst first, and if the need for another cycle, the day 6, with a caveat saying your response may not be good as the previous cycle.
Okay.
So that comes about the thing. So with time lapse, what happened is our understanding improved.
That's what.
But from 2008, we are doing the day 4 embryo transfer. So it's not with time lapse. One thing I wanted to add was, no embryologist should feel inferior that they don't have time lapse. That's one statement. Time lapse is a technology which makes you make less mistakes, but it does not improve the pregnancy rate. That's a fact. It gives you more information to explain a failure. So it will be useful in your failure analysis. It will be useful in giving you better quality inputs of information. But nobody at any point should feel inferior that they don't have time lapse and they're doing inferior work.
That's true.
And I'm giving that statement after using time lapse for 2 years.
So you routinely in all your cases are using time lapse, or there is any selective
that's
case
For every patient, ma'am.
For every patient. Okay.
Because what I felt is like this: if you use technology, use it completely.
Yeah, absolutely, absolutely.
And second thing is,
what did you find in the diabetic men?
You're saying something, madam?
No, continue, please. I'll ask later.
We opted for this method. The reason is, we felt if we use a technology, we were convinced. I was studying the technology from 2016. And at that time, Diego said, this is not the right time. There is still some more time to mature. The maturity of the technology happened around 2018-19 with the improvement of the camera systems, with improvement of the humidity, and some tinkering of the models. Ultimately, if your clinician and your embryologist are not spending time with time lapse, then it's a sheer waste.
Yes.
True.
Otherwise, you're losing that extra information of communication between you and the clinician. I believe time lapse is all about information and communication to the patient, and planning and understanding where we stand, and giving a rational explanation possibly to the patient of a failed IVF cycle. Otherwise, it's a bucket where you close the door in other things, you're opening the door and seeing it. What's the difference?
Mm.
Which a change in humidity and lots of electronic parameters will give you the information just like an iPhone. Unless we use our iPhone to the total extent, there's no purpose in buying an iPhone. That's my personal belief.
Right. Thank you, sir.
True.
Dr. Bankara, sir, what is your opinion about time lapse? Do you suggest, do you propose it as a blanket universal usage in all cases, or, do you motivate people to buy it or something, like if you are getting benefited by it, obviously?
I think we had installed the time lapse about 6-7 years back. For the last 2 years, we have completely stopped using it because it is too expensive. That is one. Second, we can only fit in 72 embryos, 72 slides at a moment. So we are many days left with patients more than that. So if we want to move into time lapse, we need so many more time lapse incubators, and it is prohibitively expensive. So, and we have analyzed our results umpteen number of times. It has made no difference in the pregnancy rate. So we have, for the last 2 years, actually shut it down, and we have just kept it on the side.
Do you have any plans?
Then I can borrow it from Manish bankers.
Sorry?
Then I can borrow your time lapse from Manish bankers.
Absolutely no problem.
You also want one, sir. Dr. Raju, before the installation of time lapse, how many times were you observing the embryos? I mean, you're transferring on day 4, but you're observing them on day 1 or even at day 2, day 3 also?
Most of the time, like I'm a clinician and a half-hearted embryologist, in the free time hanging around in the lab. So, and with time lapse, what happened is I had more free time. So my knowledge of embryology has improved, which was relearning, if I say. And my clinic, you're well aware of the protocols of my clinic more than me. You speak with my embryologist and my team more often than I do.
No, but I would say one thing, that time lapse is certainly a better culture system because it does allow for uninterrupted culture. The question is the cost justified? That is the biggest issue. I mean, in terms of a culture system, it is undoubtedly better than the convention. There are no two views about it.
Yes, sir. I would like to add some more thing. If you're having lots of bad patients and failed IVFs, your culture system makes a difference.
No,
and
but
if
so
you're getting lots of
so what we have moved is one incubator per patient policy. So one patient gets one mink incubator, and we don't open it. And it turns out to be cost effective rather than a time. Though the amount of information we get is not so much, but at least it does provide uninterrupted culture.
Sir, about the junctional zone, I wanted to know, Dr. Rama Raju, sir, you were talking about junctional zone and correlation with the pregnancy rates. And the lesser the junctional zone, the more the pregnancy rates that you had quoted in that your particular slide. So, which particular day do you start monitoring it, or regularly? And throw more light on that, please.
Actually, the junctional zone is done throughout the cycle. Like we do around 4 to 5 scans in a stimulation protocol. Unlike others, after the first dosage, we don't call them on the 9th day. We do a scans on alternate days. And in the alternate days, we measure the junctional zone along with the endometrium. And in the group in which the junctional zones are higher, we know that they have a lesser implantation potential than others. That's the data, but I don't have an explanation, the exact reason why a 3 and 4 millimeters making such a difference. Because we are typically taught that junctional zone role comes at 10 millimeters.
Yes.
In adenomasis. There is a similar work from Brazil where they did the junctional zone on the day of the embryo transfer, and they also reported the exact same values like we did it. We feel the NK cell, the junctional zone are all different ways of looking at the same pathology in different dimensions. Because when you look at it, the spiral vessels go through the junctional zone. The NK cells activity are at the spiral vessels. So we are in the evolving area of immunology of implantation. That's where future information might help us to understand it. Here I've just put across a data that a larger junctional zone might have a decreased implantation. If my time-lapse embryo is perfectly fine and I don't get an implantation, then I look at my uterus and my immunological factors and do a deep dive to look at other factors. That's how I would like to look at it. If my embryos are bad or they're not perfect, then why should I look elsewhere when the answer is in front of me?
Right. So maybe one can correlate the junctional zone and the uterine NK cells. We can do further studies. Maybe you can do something like that and correlate whether if the uterine NK cell was greater in those where the junctional zone was greater. So maybe something like that can be correlated and found out.
Because our understanding of NK cell is improving. 2 years back, the understanding was different. Now it's getting different.
Right.
So, and the second thing is to get access to genetic material of the biopsy at that point, the patients will not accept. That's a fact. So we are looking at pieces of information from different dimensions, but later, as we understand before, a comprehensive study can be done, but in a practical private sector, I don't think I'll be able to do it.
Can I ask a question? Let us say you have a young patient, had 2 embryo transfers with 2 good blastocysts put back each time. The 2D ultrasound is good. What would you do differently now for this patient, or how would you analyze? Because this is a challenge which everyone faces. Young patient, 4 blastocysts, 2 attempts. What do you do differently now?
I don't do anything differently. I just repeat the same. Why should I change when something is normal?
But why did it change? The patients asked us, the embryos were good, the endometrium was good, you did well, you said the embryo transfer was perfect, but still it did not click. So
then I tell them a philosophical answer. There's a difference between creating life and maintaining life.
So next time we'll say that.
So you wouldn't want to check on the ERA or anything also in that situation, sir, when the 4 blastocysts have been implanted?
Because what happened is before time lapse, we used to have that enigma, but after time lapse, seldom we have 4 good embryos without any adverse events. I would say that time lapse is useful in deselecting an embryo, and time lapse is useful in doing a failure analysis before you look at other areas for abnormalities.
So the key is the embryo, sir, as you say.
Yeah, key is the embryo, an euploid embryo, and time lapse will give you indicators that something is wrong. If everything is right there, then look at the womb and the other immunological factors.
So how often do you think it is the endometrium which is responsible for implantation, and when would you look for the endometrial factor, and what would you look for there?
Because we have a policy of routinely doing the junction zone, routinely hysteroscopy, not every time for every patient, but for every patient we do a hysteroscopy and we do an infection screen. So here we rule out a significant amount of pathology. Of late, we are trying to look at the cervix also, because that is one area we don't look at.
In the infection screen, what particularly are you doing for PCR for what all? Mycoplasma?
Like it comes as a kit, like it's for tuberculosis, mycoplasma, uroplasma, HSV, HPV 32 subtypes, trichomonas, and chlamydia and gonococcal. But the surprising thing is the HPV is very, very prevalent.
Oh.
But it would be very costly, no, sir, for the patient if we rule out, if we do so many PCR for so many to rule out infections. How much would it cost extra to them doing so many things?
Like the PCR for infection screen costs 5,000 rupees for this panel.
Okay, right, sir. Okay, sir.
And you take cervical mucus and screen it, is it?
Yeah, we do the cervical mucus screening. And for the male, it's the urine and the semen sample.
Okay.
Sir, you said
what about the role of various adjuvants that people have been using for recurrent implantation failure? Are you a believer of any of the adjuvants? Scratching,
no, the answer is I'm ignorant in that area, so I don't go into wherever I'm ignorant.
Okay. So now I have one case here. I would take comments from both all four of you, Dr. Banker, Dr. Raju, and both our embryologists. I'll just share the screen, give you a short history, so that I want to know how exactly do you stimulate your patients, what exactly you do in those cases. So one sec, I will just share my screen. And is it okay? Can it be seen, sir?
yes.
Yes, ma'am.
Okay.
You have to move to slideshow if possible.
Yeah. This is this
That's
lady.
okay. Yeah, that's fine.
This is lady, 33-year-old teacher by occupation, married for 3 years. Now she comes for treatment, advice that she wants to conceive, and now treatment regarding her conception. She came to me in May 2020. She has regular cycles but has dysmenorrhea, and we just went for investigations, and though everything was okay, but AMH was very, very low. HSG tubes were okay, HSA was normal, and on ultrasound there are 2 fibroids, one on the posterior wall around 3 centimeters, slightly indenting the cavity, and 1.4 by 1 centimeter fibroid on the this was actually the one was on anterior wall and one on posterior wall. There is some mistake here. And when we did her day 2 AFC, there were 2 follicles on right side and 2 to 3 small follicles on the left side. So I just want to Dr. Banker to start how you would, what you will do, how you would go about her, IUI, IVF, any adjuvants, and in IVF, what stimulation protocols and all. And then Dr. Raju can do his way.
So firstly, I think I would definitely advise IVF and not IUIs, looking at her such poor ovarian reserve, that is one. I would check her endometrium in the pre-ovulatory phase, because this slight indentation, I really want to be sure how deep that indentation is. Because in this patient where the oocyte quality and number is going to be low, if the cavity is being distorted by the fibroid, maybe there is a possible role of removing the fibroid. But I would do the IVF cycle first, create the embryos, and then remove the fibroid, because waiting for a couple of months of the fibroid surgery might be detrimental for this patient. What stimulation would you give? I would give the antagonist protocol. I normally give a combination of FSH and LH, going up to a maximum of 450 units. And always culture the embryos to day 5, so that we are sure that we are getting good embryos in this patient, and then do the transfer.
Okay. So you would like to go to day 5, sir? How many embryos and all, depending on the number of embryos, and what would be any adjuvants that you would like to use before stimulating, or straight away you would,
in terms of adjuvants, I use luteal phase estradiol to synchronize the follicles, because that helps in reducing the asynchrony in an antagonist cycle. No other adjuvants. And normally I culture embryos, and more so in this patient because she's 33, she's not elderly, she's actually below 35. So even though the number of oocytes might be less, the quality will not be so bad. So in terms of that, I would always prefer, and generally I very rarely do a day 3 transfer. Otherwise, all my patients are for day 5. If a blastocyst does not form, then the patients have been pre-counseled that if there is no blastocyst, we won't do an embryo transfer.
And you would go for a fresh transfer, sir, or a frozen cycle you would do?
So it depends on our progesterone on the day of the trigger. If it is below 1.5, I'll do a fresh transfer.
Okay, sir.
Sir, her TSH was 4.4. Would you start her on
Yes,
thyroxine?
I would.
And about her fibroids, so what would you be thinking? You would leave them aside, or you would, after you have done your pickup, you've got your embryos frozen, then would you do anything about fibroids, or is it okay? We can just leave them like that?
No, as I said, I would like to see what is the indentation when the endometrium is at its peak proliferation. If there is an indentation, I would err in favor of removing the fibroid.
So do you use DHEA or CoQ or anything because her AMH is
CoQ is fine because see, CoQ and all other antioxidants we actually don't know and there is nothing to lose. But giving her 3 months of DHEA, I am not a believer of that.
Okay, sir.
And Dr. Sarabpreet and Dr. Priya, would you be, I mean, Dr. Banker is the clinician, and do you think it would alarm you? I mean, if he has got such a patient, what would the dialogue be between you and him? And how would you anticipate what would be the lab scenario? How differently, anything you would like to do differently? Both of anybody of you can take that.
Actually, we are looking at a total number of follicles expected as about 6. So you would have some, even if it is like a few, and I would assume that sir would be thinking of accumulation of embryos if there are very less number of embryos retrieved in the first cycle. This is going to be our first cycle. We wouldn't do anything drastic here. We would go with our regular protocol of having the embryos, and if the policy of the lab is to go to day 5, to go to day 5. But of course, I mean, given to me, I would decide on whether to go to day 5 based on the embryo morphology on day 3. But yeah, that's the only thing I would add. But otherwise, if the sorry, I just got out of the fever, so always coughing. So in that case, but otherwise, if the policy of the lab is to go for only day 5, they can go to day 5 transfers, but I would still have a look at it on day 3 just to select. But otherwise, in the first cycle, we wouldn't do any drastic, but nothing much.
Dr. I'm not sure. I didn't hear about the Semen Profile. Did you mention there is any?
That was okay. That was absolutely good.
Would you like to go for a IVF or a ICSI in a low oocyte yield, because there is no evidence for going for ICSI.
Yeah.
We as a lab, we don't mind going for IVF even if you're retrieving 4 or 5 oocytes.
Yeah, absolutely. And there's absolutely no evidence to show that ICSI improves fertilization rate, or it may improve the fertilization rate, but it does definitely not improve the pregnancy rates, even in hyporesponders. Yes.
And accumulation of oocytes versus accumulation of embryos. What's your take?
Embryos. Any day embryos.
Right. Dr. Raju, sir.
The first thing I would like to ask is, what's the cause of infertility in this couple?
The cause of infertility is most probably a low ovarian reserve, sir?
The answer is no.
Okay.
Then we miss the diagnosis. Because what happens is here, when you look at this woman, you have a borderline ovarian reserves, a reversal of FSH-LH ratio. Like in a PCO, you have the other extreme 1:2 ratio, and here you have the other extreme 2:1 ratio. Her cycles will be always regular. With time, they become shorter. If you ask that lady, if you ever missed a cycle, she will say, never in my life. In fact, she will say, my cycles are becoming shorter by 1 or 2 days. And the amount of shortening will also correlate with your AMH value. But that's not the cause for infertility in this woman. We have missed the diagnosis somewhere, either at the tubal level or the infection level or at the male factor. We missed the diagnosis. Ultimately, the treatment might remain the same as everybody has said. But here, the ovary is not the cause for infertility. If we look at reserves is all about tomorrow. And reserves come into IVF where we play with numbers. But when in a natural fertility, it's all about a single oocyte. And with 24 months of cohabitation, this couple did not conceive. And we don't have a primary cause for infertility evaluation. Then whatever we do after the first cycle, we cut a sorry face of not understanding what to do. I would prefer to do a deeper dive before I venture into an IVF cycle in this patient to understand what is the primary failure and what is the where ovary is a time-related factor and a constraint for an IVF outcome, but it will never become a constraint for a spontaneous pregnancy. And she did not conceive in a spontaneous pregnancy. We missed the diagnosis somewhere. And if the diagnosis has an impact on IVF, then if we miss it, then it has a relation of we wasting 6 months of our time. That's how I look at it.
Okay, so that means we could have done more of her pelvic infection screening.
I would also look at male factor in the infection
So
screening.
we do the sperm function tests.
Yes, ma'am.
Okay.
Because I feel we have missed the diagnosis here. Low ovarian reserves is never a diagnosis for infertility of 3 years duration. So here might have missed a factor which might impact the IVF outcome. So as well look for that now rather than after a failed cycle.
Okay, and the fibroids, I don't think you don't think it would be any relevance for her, or they won't be disturbing her fertility at all.
When it may not be the cause for infertility in this particular patient with that details.
So what I did in this case was, I'll just again share the screen and tell you, sir, what treatment actually we went ahead with this one. So actually she did not agree because she came for the first time and she was married for she was just 33. She said she doesn't want to go in for IVF. And it was too early for her to decide for IVF. And we thinking, seeing her AMH levels, I started her on DHEAs. Also, I started her on vitamin D, folic acid, whatever all that we start doing right from the day the patient comes to us, giving her multivitamins and things like that. So I gave her 2 cycles of IUI with letrozole, and she had a premature LH surge in her second cycle. When her follicle was 15, day after when she came for the next follicular monitoring, it was not there. And then ultimately she sort of got agreed for IVF. And I thought of doing a embryo pooling. So in September 2020, we gave her HMG, and it was somewhere around 2475. I used day 10 distributed over 10 days. And on the pickup, we got 4 COCs, out of which 2 were M2. And 3 embryos were made. On day 3, they were frozen. Out of these 4 COCs, M2 sites were 3, which made 2 embryos, which were frozen on day 3 because we had only 2 embryos. And as Dr. Banker said, he would like to take them to day 5. We had not sort of counseled her to take them to till the blast. So we thought maybe we may not go up till the blast. So let them just freeze on day 3. Again, in September, after September, again in January, again, she was again taken up. Also, testosterone gel was given before this stimulation cycle. And here we got 6 COCs. All 6 were M2s. And on day 4, we froze 4 embryos out of these. And then I gave her injection Leuprolide depot. And after 3 months, then without doing anything to the fibroids, did a frozen embryo transfer. And the beta HCG was negative. We transferred 3 embryos. Those day 4 embryos that were there, we did not culture them to day 5. Did a day 4 embryo transfer with 2 morulas, grade 1 and 1 of grade A and grade B. And so a stimulation protocol, Dr. Raju sir, what would you, suppose now you have to, we've investigated her and everything, stimulation protocol that you normally follow. I would like to know that from you. And embryologist in charge, we've already spoken to that, how they would deal with it, and which day transfer, whether fresh or frozen, day 3, 4, 5 you would do. Fibroids, whether you were not this thing, you did not want to disturb the fibroids. So all these things I would like you to comment upon now, Dr. Raju.
Like Manish Banker said, I would definitely give LH supplementation in this patient. There's no ambiguity about it. The second thing is the premature LH search was when your FSH is on the higher side, you might have an ovulation on the 10th day or 11th day. So you're missing that thing because when your AMH is 0.7, your cycles might get shorter. So it might be a natural surge, but we are thinking a premature surge because when the reserves are lower, the follicular phase shortening happens. So I would prefer a longer protocol with a lesser dose of depot preparation so that my ovary does not get oversuppressed. But the starting dose, one thing I was a little surprised was your total dosage of your units was less than 2400. Your total dosage was 2400, I think.
Yes, sir. One cycle it was 2400. The second cycle it was 2475.
24. So there, if it's an antagon protocol, I would prefer to give it from 1 day before the onset of cycle or on the day of the cycle so that I get the recruitment better. Or if it's an agonistic protocol with a depot with a longer duration of starting dosage instead of the onset of period, I might wait for 3 weeks and then start the stimulation at 300 units. I don't cross the FSH units 300. But since I do LH formula polymorphism, I might give 37 or 75. But since you're not doing it, you can directly start at 75 units of LH. And regarding the fresh or frozen embryo transfer, I'm really not bothered. Just like Manish Banker said, the progesterone value makes a difference. And regarding the embryology information, a much closer assessment of the quality of the embryo is more important in this patient rather than the stimulation protocol because you're getting 3 and 4 embryos. And totally you have transferred totally 4 or 5 embryos till now. So more emphasis on the oocyte quality and the embryo assessment is what I would look at before I say where do things stand for that patient. The third thing is I would not like to waste any more time because if I look at the records from the time the first AMH was diagnosed at 0.7, it's almost 1.5 years now. Either because of COVID or because of the stress of in between the cycles. So we are running against time. Those are the things I would talk to the patient.
Okay. And so this cycle that I don't know which exactly, the one that we did and it failed, and the next cycle, she came with a urine pregnancy test positive, sir.
I'm not surprised.
Yeah, so she next very cycle it was her periods. We had transferred her in April, and May she got her periods, and on 22nd June she came, and we did her urine test. Beta HCG was positive, and now she is 8.5 months. All her embryos are with us, so and it was a spontaneous conception. So that is, I mean, it was a little tricky in the sense the embryos, we tried hard, and again, without doing anything, she conceived. So that was something I wanted to hear comments, your discussions, whether something differently should have been done or whether it was done rightly, and why she conceived, how she could conceive spontaneously in the next very cycle.
First of all, when we look at it, we didn't have a diagnosis. That's one thing. Second thing is the embryos are decent. And the third thing is maybe we didn't critically ask the sexual history, the duration of cohabitation in the current era, and being COVID time, did they not have unprotected intercourse during the in-between time? Because a lot of time COVID people were not planning pregnancy for the risk of viral tetragenicity. But some of the histories we could make out. The other side of COVID.
Maybe. So that is, I think in the chat box, sir, we have certain questions now. We can take that. Dr. Harita is asking, is there a cutoff range you would take for your FET before starting the progesterone?
Personally, I don't do the progesterone value because progesterone value should be done by mass spectroscopy, and nobody does it by mass spectroscopy. And so that's the reason I don't do it. But I don't, I respect other people's way of doing it, because in IVF, there are many ways of doing the same thing. And there are many ways of doing the same thing in the right way. So personally, I don't do the progesterone. Personally, we transfer in the fresh cycle unless the patient says, I don't want it. I don't make the decision, the patient makes the decision. Otherwise, I would prefer to do the transfer, because a significant number of cycles even now are long agonistic protocol.
Manish, sir, you do all fresh cycles or frozen cycles? What do you do?
Again, it is individualized. So we do an all freeze if the progesterone levels are more than 1.5 nanogram. This elevated progesterone is seen in less than 5% of the patients. Second, we do an all freeze when there is a risk of OHSS, which is more than 15 oocytes or follicles of more than 17. We do it for patients who are for pooling, for PGT testing, or for ERA testing. And we do it for patients, small number of patients where suddenly a polyp pops up, which was missed or not diagnosed earlier. So for an endometrial factor. But if everything is within the normal parameters, we do fresh embryo transfers.
Okay. Okay. So we have another question, sir, Dr. Banker, sir, for you. How to give luteal phase estradiol? And can you please suggest the preferred dose and the preparation?
So the logic from this comes in that the follicular recruitment starts in the very late luteal phase. The FSH starts to rise a couple of days before the onset of period. And in a poor responder or in a patient with poor ovarian reserve, this can lead to early recruitment of some of the follicles. So to synchronize this, we want to prevent this late luteal surge from happening. So you can give any preparation of estradiol. I use the estrabed. You can use estradiol valerate also, estradiol hemihydrate also, and I give it in a dose of 2 milligrams twice a day, beginning 1 week before the expected onset of periods. And we stop it on the first day of the period. It will not delay the period. They will get their periods on its time. And the day the period starts, she stops the medication, and we do a scan and start stimulation from the second day.
why estradiol, sir? Why can't we use progesterone? Does it differ?
See, progesterone will not suppress the FSH surge. It is only the estrogen which will suppress. And if the patient is on a progesterone, she will not get a withdrawal. So for a withdrawal, if you are giving progesterone, you will have to give a 5-day period. And that 5-day period will give sufficient time for the surge to happen. So for synchronizing, you need to prevent the FSH surge without delaying the period, and only estradiol can do this.
And OC pills, sir?
So OC pills, again, you will have to give a 5-day pill-free period. And second, OC pills for 15-20 days leads to profound suppression.
Okay, so a washout period is much longer in OC pills, and then that is why we need to just...
Yeah, so estradiol does not have any washout period. She stops it on the first day and you start stimulation from the second day. Actually, we are just, our paper is in print in Fertility Sterility. We are also giving estradiol in the follicular phase to synchronize donor cycles. So we start estradiol from the second day of the period, and we have given it for between 2 to 8 days and then start the stimulation. Because in a donor, it is immaterial where what the endometrium grows, and this beautifully synchronizes the follicles. You can start the donor stimulation on any day that you want.
Okay, so if suppose a donor comes today and another donor comes on 5th day, so all of them you are putting on estradiol?
It has to be started from the second day of the period, but then you can give it up to 8 days before you start your stimulation.
Okay.
It will prevent the recruitment in that cycle.
So it is something like some people give antagonist in the on day 1, day 2, day 3 for the synchronization.
This is so cheap. This is so cheap.
Okay, right, sir. And what do you consider is the best FET protocol for young POR with regular cycles?
I think the jury is out there. A natural cycle should be more physiological, but it is more intense. I mean, needs more intense monitoring, and it is difficult to program the schedule in busy clinics. So we prefer the HRT protocol. And thirdly, in some patients with POR, they might be having anovulatory or oligo-ovulatory cycles, where again the luteal phase may not be so good. So I use HRT, but primarily from a convenience point of view. You can schedule everything.
So some people, but there is another question. For down-regulated HRT, FET cycles, can we give leuprolide depot on in the previous cycle on day 21? And how long would the effect last? And from day 2 now, should we again give some antagonist or something, or that single injection is good enough?
I think for HRT, typically you do not need down regulation, because your estradiol itself will act as a prevention. I mean, it will prevent ovulation from happening. But sometimes if they escape this, then I give a leuprolide depot. But otherwise, giving depot, I mean, delays treatment for one cycle for every month. I mean, for every attempt. So I don't, as a routine, I don't give any depot preparation.
You, sir, Dr. Rama Raju, sir, how do you prepare your...
No, I agree with whatever Manish Banker says. It's a similar protocol.
Okay, sir. Right. And after 8th day in donor, after giving estrabet, sir, you start stimulation from day 9 is another question. So
it is not day 9. The estrogen is given for any number of days. We have tried it till day 8 or 9. And this is primarily because you have a donor, but you do not have a recipient ready. Then this is the best thing. You can continue the donor stimulation and you can start the stimulation once your recipient is ready.
Okay, so that is just to keep the donor in hand till the time we get. Right.
Plus, I think if you give the donor a pill in the previous month, you are not sure whether she is going to take the pill or not.
Right. Okay, sir. So I think we are done with all the questions, and that was a wonderful, wonderful discussion, and absolutely experienced answers from the Dr. Sonia ma'am has now opened her camera. I would like to also comment.
I enjoyed myself sitting on the other side of the fence. Thank you very much. With no questions to answer. Thank you.
Okay, today is you don't want, you are not in a mood to answer. Huh? I think next time when you are a commentator, you'll have to answer all the questions.
Thank you.
In the meantime, there's one question. In HRT, FET cycle, if there's follicle of 17, 16, 18 mm on day 11, how should we proceed?
No, if it is a HRT cycle and she has grown a follicle, you have to cancel only. You don't have any choice. So cancel, and I think these are the patients where you can consider giving an agonist depot to prevent this from happening again.
Right.
So there was, there was one small study, sir, which said that if there is an escape follicle in the HRT cycle, your implantation rate might be better. But then it's yet to come out other things, sir. But there was a very small study which said that, sir.
Okay. So thank you so much. Thank you, Dr. Rama Raju, sir, Dr. Banker, sir, Dr. Sarabpreet Singh, and Dr. Priya for your time, your inputs, and the wonderful talks, and the amazing discussion that was there, and the absolutely practical inputs that you've given from your practice. So thank you so much, each one of you, and I would thank Jagsonpal, and over to Dr. Deepika for thanking everybody.
Thank you so much, all the experts present here today. And this session was actually digital partners were the Naari division of Jagsonpal. And we have recently launched PRORETRO, micronized dydrogesterone 10 mg tablet, for which the API is also being manufactured by Jagsonpal. I'll just share with you this small clipping of a video.
Jagsonpal Pharmaceuticals Ltd proudly presents PRORETRO, micronized dydrogesterone tablet 10 mg. Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for PRORETRO.
So looking forward to the support by all the specialists who have joined us. PRORETRO, assisting motherhood, delivering happiness. Apart from this, our dienogest 2 mg tablets as EndoReg for medical management of endometriosis and EAPP. And for fibroids, medical management of uterine fibroids, we have Fibristone 25 mg, mifepristone. Next is another webinar coming up on 3rd of February. The Zoom ID is mentioned here. Please do note and register now. And we look forward to see everyone in our further programs as always. Thank you so much, Dr. Jyoti Malik, and all the experts present here. Bye-bye.